I'm here on behalf of the Ministry of Health through the National AIDS and STI Control Program, and I'll be giving a brief overview of our HIV testing and counseling among the key populations. This presentation will primarily cover the MSM, the injecting drug users, and the FSWs, female sex workers. And to start with, I'll start with where our new sources of new HIV infections are coming from. And if you look at that pie chart, a third of all new HIV infections in Kenya are attributed to the key populations. You can see the 15%, the 14%, and 4% who are the IDUs, SSWs, and the MSMs. Sorry. The HIV prevalence by type of KP, sorry for that typo. If you look at that table, FSWs have HIV prevalence of 29.3%. If you compare that with the migrant sex workers, 23.1%. The MSM, and this study looked at in Nairobi and also in Kisumu. In Nairobi, the MSM prevalence is about 24.5%. But an average of 18.2% if you look at across all the populations and their ages. Then men who have sex with men who are sex workers had a higher prevalence of 27.3%. In Kisumu, we interviewed MSMs who are a bit younger, and the prevalence was 11% actually. And those above the ages of 24 years had a prevalence of 25%. Injecting drug users in this country overall have a prevalence of 18.7%. But if you look for those who used to share needles before we had the program, because this integrated biobehavioral survey was carried out in 2010-2011, and we did not have our needle and syringe program, the prevalence was 31%. And you compare that with those who were not sharing needles, which was 5%, lower than what we have as a national prevalence. We have data also for the prison inmates, another IBBS that was also conducted in 2010-2011, and the inmates have a prevalence of about 19% for the females, and those males is 6%. And in the maximum prison, 16% versus 13% for male and females. Fisher folk have also a high prevalence of HIV, and it comes up to 26.2% and 6.2% among the males, and females 28.2%. The overall national prevalence is 5.6. So if you look at that, the key populations actually are like 4 times more than the general population. Do we know where they are? Yes, we know where our key populations are. And the first map looks at the female sex workers and where they are. And you can see the concentrations. My extreme left is a coastal region, then there is a Nairobi area and central, and then there is a lake region. That's where you can see the density increasing for the key populations and the sex workers. The other map is for the MSMs, and this is just to show you that we know where our key populations are. And if you have to target HIV testing and counseling, you really need to know where the hotspots are, you really need to know where the key populations are. This is work that is done by the key population themselves, and that's a map just showing how we normally do our micro-planning in this country, using our peer educators who are members of the key populations. Now, HIV testing and counseling is basically one of the key strategies in our key populations program. And what you can see there is a guideline that we have for Kenya, and that is a guideline that really sets the standards for HIV testing in this country. HIV testing and counseling is actually covered as one of the very big modules in that guideline. And this guideline was revised last year, and we took into consideration the WHO guidance. There are principles, not only for key populations, but generally, but I'll just talk about some of them that would be looking at key populations specifically. But as a basic principle, HIV testing must always be voluntary and free from coercion. Even if you have a stigmatized group, even if you have a group that is isolated, still their freedom still stands, and it has to be voluntary, even when you go to those outreaches, and no coercion at all. And we have to follow the 5 basic principles, the 5 C's, which is the consent, the confidentiality, and these you talk about outreaches. You don't want to know whether, even when you do outreaches, whether you still maintain this confidentiality. Then counseling, somebody would ask when you go for outreaches, how do you do it? And it is done. It has to be done as one of the minimum standards. Then correct results, which is very, very key. Remember, this is somebody you might meet today and you don't meet them tomorrow because you're an outreach and somebody say the issues of migration. So you have to make sure that you give the correct results and then link that person to care. In the wake of 1990, I think you don't want to lose anyone that you have tested. It is important there is a clear and robust links between the testing and HIV prevention, treatment, and care services, even though all the services may not be provided by one provider. HIV testing and services for key populations in Kenya is aligned to the current Kenya National HTS guidelines and the WHO guidelines. And if you look at that, some of the things and the breakthroughs for the key populations is that we are able now to test people who are under 18. We used to do it, but I think it was sort of illegal because you could not record them as under 18. You just write in the register as under 18, but now we can say 15 to 18. So for key populations, and the national guidance for the key population recommends the quarterly HIV testing. So as opposed to the general population, for all the key population members, we are supposed to test them every quarter and report all the quarters. I know some partners, we still report once. So we are killing the spirit of these people who have to go and look for these numbers every quarter. So as a prevention program, I think it is important to say that HHTS cannot be the starting point for key populations. There are other issues that happen. Before you meet this person for the first test, there are so many things that might have happened. And as a prevention program, I think these are things that we really need to look at. Key KPs experience several barriers to accessing HIV testing and care. Some of them are fear of a positive test result. Most of the sex workers will tell you the first time they got tested they were negative, they were really happy because somebody does not imagine I've been having all these many sexual partners, maybe some condom bursts, maybe that time there was no PrEP, and I'm negative. I think it's usually a very happy result that is usually celebrated. But there is that fear of a positive test result. Inconvenient clinic operating hours. Remember, sex workers, most of them will work at night and they would want the clinics to be opened at night because most of the day they are sleeping. So they want to rest during the day, just like a nurse on night duty. Yeah, if you want to give services, you don't give when they are sleeping. You have to give them when they are awake at night. But you realize that most of our clinics, maybe by 9, they'd have closed. Then fear that the results will not be kept confidential, and this has come up, especially when we are rolling out the self-testing and you have to discuss your the way to go about it with the outreach workers and the peer educators. So there is their need of key populations making sure that their results are kept in confidence. There is fear of insensitivity, like when this person finds I'm a sex worker, I'm now HIV positive, how will they take me? Stigma and discrimination from the healthcare providers, but of course this is changing, but it cannot change overnight. We still do sensitizations, but we make sure that at least we provide KP-friendly services that are able to respond to the needs of the sex workers and the other key populations. Inability of programs to address other felt needs of the KPs. I think last week we were in Mombasa and most of the sex workers are telling us that we can get HIV testing in every facility. What is it that you're offering in these standalone sites? What is it that extra that I need? Is it family planning? Is it other SRH needs, cervical cancer screening? What are you offering? What is it that you're offering that is so special and that I cannot meet in the other service delivery points? Then overemphasis of HIV testing is becoming the first point of contact, and then the issue of violence against the key population. So HTS clearly for a prevention program might not be the first time you're meeting this person. You may want to meet them when you're maybe addressing stigma and discrimination, when you're addressing violence for these people, and any other services. So given the hidden nature of the key populations, building trust and mobilization of the peers is very, very critical because these are the point of contact, and peer education is a backbone of the key populations programs. The aim of building a robust outreach program with key populations before offering HIV testing and counseling is to build trust with the community and to empower them to understand the need for regular testing. Building this relationship with key populations prior to testing will increase the uptake of HIV care and treatment services for key populations found to be HIV positive, and then developing a risk reduction skills for those who are found to be negative, to remain negative is very key. Now with the current programs, majority of them, we are focusing on that positive person. We should always remember that there's a negative person that we need to maintain. We have several settings in Kenya that we are offering these HIV testing and counseling for our populations. We have the standalone HTS facilities which are managed by agencies implementing the KP program, and they offer services besides the HTS. For example, STI screening, ART. So that's one model. The other model is outreach, where you take the services to the sex worker. You go to the hotspots, and in that hotspot, it can be door to door. You find there are some places where you have brothels, and you can go door to door. So that one is outreach, HTS. And then we have the health facility based where these key populations can now be tested in where all the other people are being tested. And the facility is not specifically meant for KPs, as opposed to the standalone that is just specific for key populations. There are new strategies that we are trying to make testing more accessible, for key populations. And we are also trying to see, I think there is this popular statement of where the yield is. So we are also trying to help programs to make sure that they gain this yield. Yeah, so we are helping programs to do that by, they provide hotspot data, which we analyze, and we make sure that we know how many people have been tested there, how many are remaining, and for the programs, they will only go to where the gap is. So if you have, where you have 100%, you don't need to go there. You'll go where you'll have 82% because you still have some numbers that have not been tested. Now, if you look at that program, maybe they are saturating, because if you remove the number of people who are HIV positive, maybe they are reaching everyone. So what happens when you saturate and hotspot? What happens when you're not able to get more numbers and your donor is asking and pushing for numbers, and you have had a very successful prevention program and you've tested everyone, you have removed the positives from the number, and now you're at 80%. Where else can you go? So it's either you expand and you move from that hotspot and go to other, and you maintain those numbers. Otherwise, sometimes we forget to see these and we want to see 100%. But for key populations, if you test somebody, of course, you have to remove them from the database where you have the people who have not been tested. The new strategies, again, that are being tested around is self-testing. And we have a big self-testing program that is being funded by PEPFAR. Of course, you remember that this is part of the national policy. We just revised our guidelines, and this is part of it. And in Kenya, based on KAIS 2012, 67.3% of all the women are willing to use a HIV self-test kit, and 70% overall. Key population implementation science study funded by PEPFAR on self-testing is in multiple KP sites and in different counties, and we are waiting results to just see how it has worked and how we can roll out with the key populations. The other strategy is we're also looking at the biggest yield again, and we're also seeing the key populations who've been left behind, and these are the young key populations. We realized that in one of the studies that we conducted last year, the transition study showed majority of the young sex workers are actually accessing testing services. The only thing that we noticed is that they're not accessing services in these standalone clinics, but they are getting tested somewhere. Yeah, either in a normal facility just for anonymity, but they are getting tested, but not at the drop-in centers. So we are also trying to investigate to see why is it that they're not coming to the standalone clinics where we actually think we have 100% friendly services. However, their access to other services is still limited, so you find they get tested, but they don't have any other services. Consultations with young key populations to understand how to use HTS as the entry point to other services and develop a comprehensive intervention package is also ongoing. And we are exploring the use of new HTS policy to reach young people, which at least has given us a leeway of 15 years.
1 minute, please.
Sure. So we have regular monitoring testing data across the 82 programs for the key populations, and that just summarizes what we have. And you can see, when you use program data, we still have partners who are still not reaching 50%. So you'd want to know why. But this, you add 29% because you have to remove the people who are positive. Now, if you look at this data, the regular monitoring, testing, and linkage, you still have gaps in the second 90. So we might be testing, but we are not linking those people. And if we are linking, we are not reaching all the numbers. So we are losing some. Even if it is 2 people, I think it is very important and we have to reach them. We normally conduct annual surveys for behavioral outcomes, and this is the data that it shows. It shows that HIV testing among key populations is still increasing. We conducted in 2014 and 2015. And for your information, the acceptability of testing among key populations is over 98%. So anytime you request a key population to be tested, 100% will accept. Maybe 1 or 2, maybe because of time, but rarely do they decline to be tested. So they actually want to be tested. We also need to know where we need to take these services. From those slides, you're seeing that for those key populations who are reached by peer educators in the last 3 months, you can see the number there. At least 79% were reached by a peer educator. Compare with those who visited an intervention. They went to a clinic, a standalone clinic, or a mainstream clinic. Again, if you were to target, then you would go to the option that is reaching more, and you do more outreaches so that you can use the peer educators. There are some challenges that we are addressing. For example, to achieve 90-90-90 among key populations, we should do a good job for the first 90, and we also need to do a pre-job. You know, just addressing issues of violence so that these people can be able to access this first service where you want to reach them. A robust peer-based outreach using micro-planning and individualized tracking is also a must for the 90-90-90. However, the focus on testing as a starting point is pushing implementing agencies to compromise the pre-work before the first 90. Different targets and guidelines on the national government and funders sometimes cause confusion. And the Kenya national guidelines recommend quarterly testing, but you find that partners just want 1 test per year. So even if you test this person 10 times, they will only report once. The main challenge is linkage to care, and we have to address that. We also need to focus on the negative KPIs so that we maintain a good prevention program. And HIV prevention programs for key populations would have to focus on that strategy too, of keeping people negative. Now, there are emerging issues, and that's my last slide. And I kept asking a question. Is 90-90 pressurizing programs to be treatment care centers as opposed to prevention programs? For key population, does prevention start before or after HTS? Should dropping centers offer people-centered services or program-centered? And then condoms still remain a cornerstone for HIV prevention among key populations, and you need to focus on prevention for key populations and not only prevention with key populations. The difference is prevention with key populations is making sure that we don't transmit HIV to the general population. But when you do key populations, then you're preventing that one sex worker who would have gotten positive today. So we need to know the difference and use both. We do prevention with and for key populations. Thank you.